Hello everyone, my name is Sudhir Kathuria and I will be presenting radiology for audiology. I recently gave this presentation in person at Maryland Academy of Audiology conference and I am recording the same presentation for anybody who attended the conference and would like to review the material again, and also for those who were not able to come to the conference and are interested in this subject. Little bit about myself. I am board certified radiologist and I have CAQ certification in neuroradiology subspecialty by the American Board of Radiology. I've been in practice for about 20 years. I spent initial 4 years at University of Rochester, New York, where I did my fellowship training. Then I worked at Johns Hopkins Hospital in Baltimore for about 7 years. And in the last 8 years, I have been in the private practice and I currently serve as Director of Neuroradiology at Charter Radiology in Maryland. I do not have any disclosures except for small honorarium. These are the learning objectives of our session. We will go over the basics of the CT and MRI imaging techniques and differences between the two modalities. We will cover the specific role of the CT and specific role of the MRI in various audiologic conditions. We will learn when to use the contrast material both in the CT and MRI imaging, and we will also go over some contraindications of both CT and MRI techniques. Most common conditions for which we do the temporal bone imaging include conductive hearing loss, asymmetric sensory neural hearing loss, tinnitus, vertigo, ear pain, and symptoms related to the trauma such as hearing loss, autoria, facial paralysis, or vertigo. Different imaging modalities that are utilized in temporal bone imaging includes CT, MRI, and PET-CT study. By far, CT and MRI are the main modalities. PET-CT is utilized in the setting of cancer patients, so we will be focusing mainly on the CT and MRI in this session. This is the picture of one of our CT scanner. The main part of the machine is this donut shape or ring shape gantry. Then you have a sliding table. The patient lies on the table and then the table slides the body part inside the gantry, and within the gantry, if you look at the schematic on the right, so within this ring shape gantry, on one side there is an X-ray tube. This X-ray tube emits the X-ray beams, and these X-ray beams will then pass through the body of the patient, and on the other side there is a ring of detectors that will detect any changes in the X-ray beams after they pass through the patients. And from these detectors, we generate the electric signal. That electric signal is then converted to the digital data by the analog to digital converters, and then digital data is finally projected as image on the CT computer. And from this computer, then images can be sent to the online web-based viewing system or can be burned on the CD. This is the picture of one of our MRI machine. From outside, the shape of the machine is similar to that of CT. The central main part of the machine is donut shape or ring shape, and then you have a sliding table. However, inside of the machine is very different and more complex. Instead of using the X-ray beams that we saw in the CT machine, in MRI we use multiple sets of magnets and multiple sets of coils to produce the images. So one of the very common question we get asked is when to use CT and when to use MRI. So let's review some of those settings between CT and MRI. Both CT and MRI can be complementary to each other in imaging of the temporal bones. However, each modality has its own unique advantages. CT is especially good in evaluation of the bony structures such as mastoid and and petrous apex bone. CT is very good in evaluation of the external auditory canal abnormalities such as congenital narrowing or otitis externa due to infection. CT is the main imaging modality in evaluation of the middle ear, especially for patients presenting with the conductive hearing loss. CT is also very good in evaluation of the cholesteatoma, where we can see the soft tissue density causing some bony erosions, especially that evaluation of the bone is much better on the CT compared to the MRI. However, sometimes when the cholesteatomas are very small and early stage, they do not cause bone erosion because of the small size. In that particular setting, MRI can be very helpful and more sensitive by demonstrating restricted diffusion to make the diagnosis of cholesteatoma. So both CT and MRI are complementary. On the other hand, MRI has its own unique advantages. MRI is very good in looking at the fluid filled structures, and as you can see on this image, the white bright area is the CSF fluid, and within this fluid there are thin cord-like structures within this internal auditory canal. These are 7th and 8th cranial nerves. MRI is very helpful in evaluation of the soft tissue lesions or any retrocochlear pathology. MRI is especially useful in the setting of asymmetric sensorineural hearing loss, where we are looking for any retrocochlear pathology such as vestibular schwannoma or neuroma. MRI is also very useful in distinguishing early stage cholesteatoma, as we discussed in the previous slides, and also for the evaluation of a recurrent cholesteatoma after the surgery by utilizing the characteristics of restricted diffusion in these cholesteatomas that can be demonstrated on diffusion weighted imaging in the MRI. So in certain situations, we use intravenous contrast that helps in improving our diagnostic accuracy. Contrast used in CT is iodine based and contrast used in MRI is gadolinium based. Contrast is injected as intravenous bolus followed by the post-contrast imaging. Contrast improves our diagnosis in the setting of infection or when we are worried about abscess formation, in the diagnosis of the soft tissue masses or neoplasm, and also in the evaluation of any vascular malformation. So let's discuss contraindications of imaging. We can categorize them separately into contraindications from the contrast and contraindications in the setting of CT and MRI imaging. In contraindications from contrast, we use two different types of contrast. The contrast used in MRI is gadolinium based, and any adverse events or severe allergic reaction from gadolinium based contrast is extremely rare. The contrast used in case of CT imaging modality is iodine based, slightly higher chance of allergic reactions, but overall incidence of allergic reactions from CT contrast is less than 0.5%. And within these reactions, the majority of them are mild and are not life-threatening. And these can be easily managed with observation, reassurance, and with supporting measures. Now, severe and potentially life-threatening adverse events, they occur. They are rare and they are unpredictable. Majority of the life-threatening contrast reactions will occur within the first 20 minutes after the injection of the contrast. And we have trained healthcare professionals on site, and we have a special kit with medication that we will use to manage these severe allergic reactions. The other contraindications for contrast will be in the setting of poor renal function, especially with GFR value below 30, and contrast are usually avoided and contraindicated in the setting of pregnancy. Now, coming specific to the CT modality, if there is any metallic foreign body or post-surgical hardware placement in the area we are doing the imaging, these will produce significant streak artifacts and they will lower the image quality. So this is more like a relative contraindication of using CT when we have a metallic foreign body adjacent to the body part that we are interested in imaging. Similarly, in MRI, if there is a magnetic foreign body, that will produce a lot of artifacts and limit our evaluation of the body part. The other contraindication for MRI is cardiac pacemaker or programmable shunts. These are relative contraindications. Some of these can be imaged in the hospital settings, um, but these are the relative contraindications. So now let's shift our focus on the imaging. I will briefly go over the basic normal anatomy and appearance of the temporal bone on both CT and MRI imaging. And after that, we will look at several clinical cases with abnormal imaging findings. This is the coronal CT image through the right temporal bone. For reference, on right, we have Netter anatomy schematic image in the same coronal imaging plane as this CT. So temporal bone can be divided into external ear, middle ear, and internal ear. The external ear, we have auricle or the pinna, then external auditory canal that has two segments, the cartilaginous segment and then the bony segment. And then there is a thin tympanic membrane that separates external ear from the middle ear. Now middle ear, center part of the middle ear, which is at the same level as the tympanic membrane, is called the mesotympanum. Part of the middle ear cavity superior to the mesotympanum is called epitympanum, and the part inferior to the mesotympanum is called hypotympanum. And then on the medial to the middle cavity, we have the internal ear. Here we can see the cochlea and small portion of the semicircular canal, which are part of the internal ear. Here we have two CT images. Image on the left is the coronal CT image, same image that we saw in the previous slide. Image on the right is the axial CT image, which corresponds to the horizontal white line demonstrated on this coronal image. Now focusing on the axial image, what we see here is classically described as ice cream cone appearance of the ear ossicles. Here is the scoop of the ice cream, which is represented by the head of the malleus, and then you have the cone of the ice cream, which is represented by the short process of the incus. Please notice the margins of the ossicles are surrounded by this black air within the right middle ear cavity. So this is normal appearance. We should see this black margin surrounding the entire ear ossicles. You can also see the air within the mastoid air cells, and then coming to the internal ear, we can see the cochlea, we can see the portions of the semicircular canal. Here we have the same coronal CT image and slightly lower section of the axial CT image. On the axial, here we see the two dots of the ear ossicles. The anterior dot is the handle of the malleus and the posterior dot is the long process of the incus. And here also you can see the black air completely surrounding the ear ossicles. And this horizontal image is further slightly lower than the previous one, and we can again visualize the long process of the incus, the malleus, and also the basal turn of the cochlea and air within the mastoid air cells and air within the middle ear cavity. These are the MRI images. We have high resolution T2 weighted image in the axial plane on the left and high resolution T2 weighted image in the sagittal plane on the right. Here we can see the fluid signal from the CSF is bright white on this particular sequence, and we can visualize the internal auditory canal, and within the internal auditory canal these are the 7th and 8th cranial nerves visualized as thin cord-like gray structures. Then we can visualize the fluid within the cochlea, and this portion is the vestibule, and we can see the portion of the horizontal semicircular canal and fluid signal within that horizontal semicircular canal. Looking at the image on the right, which is the oblique sagittal image through the IAC. Within the IAC, you can see four distinct dots. Each dot represents the neural structure. Now, this is the anterior portion and this is the back of the head posterior portion. The arrow is pointing to the nerve within the internal auditory canal, which is located anterior and superior. That is the facial nerve. So you can remember with the mnemonic called 7 up. 7 up is seventh cranial nerve anteriorly and superior in location. And the nerve which is inferior to the seventh cranial nerve is the cochlear nerve. So you can remember 7 up and coch down. And in the posterior portion we have the superior vestibular nerve and the inferior vestibular nerve. So MRI can help us distinctly visualize these neural structures separately. So that was some basic anatomy on the CT and MRI images. Now we will review some clinical cases that have abnormal imaging findings. So our first case is a 12-year-old male presented with sensory neural hearing loss and vertigo. So this is a young patient. We will suspect some potential congenital anomaly. So the imaging modality of choice in this setting is non-contrast CT, which was done. These are the two axial images of this patient. Focusing on the image on the right, we can see this thin gray structure posterior to the horizontal semicircular canal. This is the normal vestibular aqueduct, and normal size of the vestibular aqueduct should be equal or smaller to that of the semicircular canal. Now looking at the abnormal side in the right temporal bone, we will see this vestibular aqueduct size is significantly enlarged, and this is much bigger than size of the horizontal semicircular canal. So this is abnormal dilated vestibular aqueduct, which is a very common congenital anomaly leading to the sensory neural hearing loss and vertigo. Next clinical case is 38-year-old male presenting with left-sided conductive hearing loss and left-sided ear discharge. So in this clinical setting of conductive hearing loss, the imaging modality of choice will be non-contrast CT. Here is the coronal CT image of this patient. In the right temporal bone, we can see the normal black signal from the air within the miliar cavity and normal black air within the right mastoid air cells. In the symptomatic left side, we can see the gray density filling all the left-sided mastoid air cells, as well as we see the soft tissue gray density within the mesotympanum of the miliar cavity, as well as this gray density in the epitympanum of the left miliar cavity. There is no bone erosion, all the bones are intact. So these findings are suggestive of left-sided automastoiditis. Our next case is 36-year-old female presenting with right-sided progressive mixed hearing loss and right ear fullness and tinnitus. These are the two coronal images of this patient. In the left temporal bone, which is the normal side, you can see very well aerated black density of the air within the miliar cavity, and you will also notice this triangular bony projection lateral to the epitympanum. This is called scutum. This is a normal bony structure. On the abnormal right temporal bone, we see a soft tissue density within the mesotympanum surrounding the malleus and incus, and also filling the entire epitympanum of the right miliar cavity. Now, very important point here is you will see that triangular bony projection is missing. So this is suggestive of erosion of the scutum by this soft tissue density structure, which is a classical finding that we see in case of the cholesteatoma. Next clinical case is a 63-year-old male presented with right mastoid pain and swelling, fever, and mental status changes. So in this setting, we will be suspicious of some infections. So this will be setting where we should utilize the intravenous contrast. And this patient had both CT and MRI imaging with intravenous contrast. These are the post-contrast axial CT and axial MRI images. Both images demonstrate this black area of loculated fluid collection located within the mastoid. The fluid collection extends into the extracranial soft tissue lateral to the mastoid, and also the fluid collection extends into the intracranial compartment in the posterior cranial fossa, and we can see this thin peripheral capsular enhancement surrounding this fluid collection. And these are the diffusion weighted images in MRI. Here we can see very bright signal that corresponds to the fluid collection we saw in the previous images, and this is suggestive of restricted diffusion, which suggests that this is a brain abscess related to the right mastoiditis. Our next case is a 24-year-old male who presented after the MVA with history of bleeding from the right ear and some hearing loss. This is a axial CT image of this patient where we can see the acute fracture line that traverses parallel to the long axis of the petrous pyramid. Now such fractures generally happen from injury impact from the frontal or the occipital region. These longitudinal fractures, they commonly involve the ossicles, they involve the tympanic membrane, and they also increase the future risk of cholesteatoma development secondary to invasion of the squamous epithelial cells into the middle ear cavity through this fracture site. The other type of fractures are the transverse fracture, which will run perpendicular to this long axis, and the transverse fractures have a high risk of facial nerve involvement, and they will often spare the ear ossicles. So here we see the horizontal longitudinal fracture that's involving the ear ossicles. Next case is a 41-year-old female presenting with pulsatile tinnitus on the right side and visualization of a red mass on the otoscopic examination. These are the axial and coronal CT images. Here we can see a very well marginated soft tissue density gray structure within the right middle ear cavity, and it's located and centered at the cochlear promontory. So this is a classical appearance of glomus tympanicum tumor. Our next case is 5-year-old boy presented with profound right-sided sensory neural hearing loss. So again, we will be suspicious of congenital anomaly, so non-contrast CT was performed. This is the axial CT image of this patient. The arrows are pointing towards the internal auditory canal. In the left temporal bone, this is the normal size of the internal auditory canal. However, if you notice on the right side, the size of the internal auditory canal is much smaller, which is abnormal. Additional CT images also demonstrate the smaller size of the cochlear nerve on the right side, which is visible as this thin gray structure marked by the arrow. If you look on the normal left side, the size of the cochlear nerve is much larger. So this is a case of cochlear nerve hypoplasia, which is the congenital anomaly. Next case is 80-year-old male who presented with mass in the left middle ear on exam. So in this case, CT with intravenous contrast was performed. These are the coronal and oblique CT images through the temporal bones. On the left side, we can see a gray soft tissue density mass that is causing the bony erosion. This mass is centered within the left jugular fossa, and the mass is extending into the middle ear cavity, predominantly involving the hypotympanum part with associated bony erosions. So this is suggestive of neoplasm, and this is a classic location for a glomus jugulare tumor. This is a 55-year-old female who initially presented with balance and hearing problems with the loud noise. She underwent surgery, and we have a post-surgical follow-up CT. This is the coronal CT image. In the right temporal bone, we can see the vestibule of the internal ear, and then we have a superior semicircular canal with the missing bone at the roof of the superior semicircular canal, which is suggestive of bony dehiscence. So this patient was diagnosed with bony dehiscence of bilateral superior semicircular canals, and then she underwent surgery on the left side where the bone graft was placed, and we can see this thick bone that's now partially obliterating the superior portion of the left superior semicircular canal, while we can still see the bony dehiscence on the right side. Next case is 48-year-old female presented with worsening bilateral hearing loss, tinnitus, and vertigo. These are the coronal CT images of this patient, and here we can see focal areas of hypodensity marked by these arrows. These hypodensities are located next to the cochlea and next to the oval window. So these findings are suggestive of otosclerosis in the spongiotic phase. So in the spongiotic phase, we see demineralization of the bony structures adjacent to the cochlea and the oval window. Next case is 54-year-old male presenting with right-sided sensorineural hearing loss with poor renal functions. So this will be clinical indication for a post-contrast MRI for the evaluation of retrocochlear pathology in the setting of sensorineural hearing loss. However, here we have a poor renal function, which is one of the contraindication to use the intravenous contrast. So in this case, MRI was performed without intravenous contrast. So these are the non-contrast T1 weighted images through the temporal bones. We can see a very bright T1 signal mass lesion located within the fundus of the right internal auditory canal. If you notice, the signal intensity of this mass lesion is similar to the subcutaneous fat. So this is a fatty mass lesion which is comparable with lipoma located within the right internal auditory canal. Next case is a 54-year-old female presenting with right-sided sensorineural hearing loss. So this patient had no history of poor renal function or any other contraindications, so MRI with intravenous contrast was performed. These are the post-contrast fat-saturated T1 weighted MRI images through the bilateral temporal bones. Here we can see bright, intensely enhancing soft tissue mass lesion located within the medial part of the right internal auditory canal, partially extending into the right cerebellar pontine angle cistern. You can see the similar level of enhancement in the adjacent vessels. This is the right carotid artery and this is the right transverse venous sinus. So this is intensely enhancing mass lesion, which is the classical appearance of a vestibular schwannoma. In the next few slides, I would like to go over several clinical cases from this particular article that was published in Radiographics from group in the Wake Forest University. This article demonstrates excellent audiology and radiological correlation in some of these clinical cases, and I thought this will be very interesting and useful for our audiology colleagues. This is case of a 64-year-old female who presented with gradually progressive hearing loss in both ears. On audiogram, we can see bilateral downsloping sensorineural type of hearing loss, most pronounced at the higher frequency and worse on the left side, marked in blue. On imaging, post-contrast MRI image demonstrates diffusely intensely enhancing soft tissue mass lesion within the left internal auditory canal, which is compatible with a vestibular schwannoma, very similar to the case that I showed earlier. But here we can see the corresponding audiogram, and on audiogram we suspect a retrocochlear pathology, and MRI is demonstrating that pathology. This is a picture of a audiogram that demonstrates a upsloping type conductive hearing loss in the right ear, and there is a decreasing airborne gap at the higher frequencies. So this type of pattern would suggest there is some stiffness in the ossicular chain or some stiffness within the tympanic membrane. So this is a case of a 5-year-old girl who presented after failing a screening hearing test in the right ear at school. We can see the audiogram shows the upsloping pronounced low frequency conductive hearing loss in the right ear. And so this audiogram configuration will suggest some ossicular chain stiffness or increased stiffness within the tympanic membrane. And we can see on the CT image of this patient that there is this mineralization of the tympanic membrane, this white thick tympanic membrane. So the normal tympanic membrane is visible as very thin structure, gray color, barely perceptible. So this is abnormal mineralization of the right tympanic membrane leading to the conductive hearing loss, which is suspected on the audiogram. So this is a diagnosis of meringosclerosis. Another patient, 8-year-old boy who had a similar pattern on the audiogram, which is suggestive of conductive hearing loss in the right ear. The axial CT image demonstrates there is a abnormal mineralization adjacent to the body and short process of the right incus. So this is that same level axial CT image where we saw the ice cream cone appearance, and if you remember, we saw that we should see this black air completely surrounding the ear ossicles. But in this case, we have a missing air which is replaced by this mineralization. So there is a joining of the lateral epitympanic wall with the incus through the abnormal mineralization, which is leading to the conductive hearing loss in this case. This is another young patient, 11-year-old female who presented after failing a school hearing test in the left ear. The audiogram demonstrates similar upsloping pattern suggestive of conductive hearing loss in the left ear. On the CT image, we can see there is a mineralization and calcification of the anterior malleal ligament that is causing fixation of the head of the malleus to the anterior wall of the epitympanum, and this leads to the fixation and stiffness in the ossicular chain, which matches with the audiogram pattern. For comparison, this is the normal side, and you can see the black hair completely surrounding the ear ossicles, and there is no fixation or calcification or mineralization of the malleal ligament on the normal side. This is a 45-year-old male who presented with 2-year history of progressive subjective hearing loss in the left ear. The otoscopic exam was normal with normal appearing tympanic membrane and no middle ear abnormality. The audiogram here shows upsloping conductive hearing loss with elevated threshold in the middle frequency around 2000 kilohertz, which is also known as the Carhart notch. The acoustic reflex in this patient was absent in the left ear, which is suggestive of there is a fixation of the third window lesion. So on the CT image, we can see the abnormal lucency pointed by this arrow, which is located along the anterior aspect of the oval window. So this is a case of spongiotic phase of otosclerosis. This next case is a 37-year-old woman who presented with 4-year history of progressive right-sided hearing loss and tinnitus. The otoscopic exam was normal with normal tympanic membrane and normal middle ear. The audiogram demonstrated upsloping, primarily conductive hearing loss with a Carhart notch at 2 kHz. The acoustic reflex in the right ear was absent, suggestive of there is a ossicular chain fixation rather than a third window lesion. And on axial CT images, we can see a thickening of the aortic capsule. You can see this thickening by this measurement tool that demonstrates 2.8 millimeter thickness. So normally this aortic capsule should be less than 2.3 millimeter. As you can see on this normal side, this measures 1.6 millimeter. So whenever we have this thickness of the aortic capsule more than 2.3 millimeter on CT, that is suggestive of otosclerosis with a high accuracy rate of 96% sensitivity and 100% specificity. So this is a case of sclerotic phase of otosclerosis. This is a case of 22-year-old male presented with the right-sided hearing loss after fall 1 month ago. On audiogram, we can see asymmetric conductive hearing loss across all the frequencies with a flat configuration, and there is a severe hearing loss around 60 decibel. So this is suggestive of maximum conductive hearing loss, which can be seen in the setting of some ossicular chain disruption. So the CT images, we can see there is a gap between the incus and the stapes bone pointed by this arrow. So this is a case of disruption of the incudostapedial joint. And on the normal side, you can see there is a connection. There is no gap between the incus and the stapes. Here we have a 54-year-old man who presented with history of total ossicular replacement prosthesis that was placed for the ossicular chain reconstruction in the setting of cholesteatoma treatment. Now the audiogram shows maximum left conductive hearing loss with a flat configuration, and we can also see there is a high frequency hearing loss at 4 kHz, which is suggestive of noise induced hearing loss. So we have a case with a maximum conductive hearing loss, and in the setting of placed prosthesis, we will suspect probably a malposition prosthesis. So the CT of the temporal bone does demonstrate there is a gap in the medial end of the prosthesis and the oval window. So that explains the audiogram findings. This is an audiogram that demonstrates the downsloping conductive hearing loss pattern in the right ear. There is increasing ear-bone gap at higher frequency. This pattern can be seen in the setting of soft tissue spanning and otherwise disrupted ossicular chain. This is a case of a 16-year-old boy who presented with left-sided hearing loss after an MVA. The initial audiogram demonstrated flat maximum conductive hearing loss, which would suggest a disruption in the ossicular chain, and CT at the same time demonstrate gap between the malleus and incus, as well as there was a gap between the incus and stapes, suggestive of both dislocation of the incudomalleal joint and dislocation at the incudostapedial joint. Now this patient opted for conservative management and denied the surgical option of prosthesis, and on a 4-year of follow-up evaluation we have a audiogram, and this audiogram demonstrates a downsloping configuration of the conductive hearing loss, which is suggestive of interval development of the granulation tissue, which is now bridging those gaps at the incudomalleal and the incudostapedial joints. So this is another pattern on the audiogram where we can see there is a supranormal bone conduction at the lower frequencies with an upsloping conductive hearing loss. So this type of audiogram pattern will be suggestive of a third window lesion. This is a case of 49-year-old woman who presented with muffled hearing, dizziness and left oral fullness. On audiogram we can see there is a air-bone gap at lower frequency due to supranormal bone conduction, suggestive of pseudoconductive hearing loss. Acoustic reflex was preserved in this patient, suggestive of there is a third window lesion. And CT image in the oblique projection demonstrates there is a focal bony defect of the left superior semicircular canal, suggestive of bony dehiscence of the left superior semicircular canal, which matches with what we see on the audiogram pattern. To summarize, we reviewed the basic imaging technique of CT and MRI in temporal bone imaging. We discussed the strength as well as differences of each imaging modality. We reviewed the basic normal anatomy on both CT and MRI, followed by some pathological clinical cases. We covered the role of CT in the otologic conditions. CT is the first imaging modality in the setting of a conductive hearing loss or when we suspect a congenital abnormality. The role of MRI is mainly for asymmetric hearing loss when we are suspecting a retrocochlear pathology. We saw cases of a soft tissue masses, a case of a lipoma, and a case of a vestibular schwannoma in the setting of asymmetric sensory neural hearing loss. We also saw cases of glomus jugulare and glomus tympanicum tumor. We discussed the role of intravenous contrast material in both CT and MRI imaging. Contrast material is especially useful when we are suspecting infection with clinical symptoms of fever, suspecting abscess, or we are suspecting any soft tissue neoplasm. We discussed the contraindications for contrast, which are severe allergic reactions or poor renal function. And we also discussed the specific contraindications for CT and MRI, which include foreign body that will causes streak artifacts in case of CT, or there is a magnetic foreign body in case of MRI, or pacemaker or hardware placement. And with that, I would like to thank you for your time and attention. I hope this was a useful session for you. And if you have any question, please feel free to send me an email at this email address.